The webinar that you're in today is writing individualized treatment plans, and that's really, really important. And really, treatment plans are the bane of existence for many clinicians. They're not always easy, especially if you have complex patients. And not only is it important for patients and clients to have those goals outlined, but it's also an issue of compliance now, and an even bigger issue with reimbursement. And so in organizations, or some organizations, and we'll talk about them, will not pay you if you don't have a treatment plan on the chart, or if you are not aligning your goals with the treatment of the patient. And we're going to kind of go through some of those pitfalls and how you can avoid those. Now, I always like to start out, whatever topic I'm talking about is the history of kind of mental health treatment. Now, this webinar is tailored more towards behavioral health, but we are definitely going to go over medical as well. Okay, so we definitely have those treatment plans, and we're going to be talking about those. Just out of curiosity, sorry, this is not in the poll question, but how many of you are medical? If you're medical, will you type medical into the chat so I can see how many folks we have in medical versus behavioral health? Because I'm having a feeling we have more behavioral health. So if you deal strictly with medical issues, can you type medical into the chat? I got no one doing that right now. So any medical. All right. Well, then you guys know what my focus is. Okay, so you do some medical. All right, I will go over how to put those in. Medical treatment plans, not a problem. Okay, so I'm getting some medicals now. All right. All right. All right, excellent. Well, as you can see, the history of mental health, I'm going to talk about that just a little bit, is the people with mental illness have been treated very poorly over the years. In the olden days, it was believed that mental illness was caused by demonic possession. You guys have probably heard of that. Or they believe someone was in witchcraft, or there was an angry god. And for example, in medieval times, abnormal behaviors were viewed. The sign, again, was the person was possessed by a demon. And if you were considered to be possessed, there were several forms of treatment that would get those spirits out of you. And none of those were ethical, I might add, but the most common was exorcism, and that was always done by a priest or some religious figure in the community. And they did a lot of incantations and prayers that were said over the person's body, and the individuals may have given some medicinal drinks or lethal herbs sometimes, or dirt. And another form of treatment in extreme cases of mental illness was something that I don't know if you guys have heard a lot of, but it's called trifiding, and it's basically where a small hole was made in the afflicted individual's skull because they wanted to release the spirits from the body. And most people that were treated by this method died. And there's actually a burial site in France, and it's dated back in 6500 BCE, and 40 out of the 120 prehistoric skulls found had those holes in the skull. So in addition to exorcism and that awful form of treatment, other practices just involved execution. People were imprisoned for psychological disorders. So none of these things were good treatment plans, right? None of these. And so if you think about it, even the deinstitutionalizing of individuals didn't start until 1955, and it didn't end until 1994. That's not that long ago. I've been a nurse for over 20 years. And so 1994 was not that long ago to me. And then we even had, if you think about it, lobotomies, if you guys remember hearing about those came about in the 1940s and 50s. And even though it was such a damaging and controversial treatment, there was a Nobel Prize in medicine that was actually awarded to the neurologist for his creation of that treatment or procedure in 1949. So we have come a long way in mental health, but we still have a long, long way to go. And so again, this is the history of treatment. This is not the direction that thankfully we're getting away from that. But we want to talk about treatment and mental health, and then we'll also in medical, and what does the treatment plan kind of include in the treatment plan. So the treatment plan is just a very, very detailed plan tailored to the individual patient, and it's a powerful tool for engaging the patient in their treatment. So treatment plans usually follow a pretty simple format, and they typically include, of course, the person's personal information, like their psychological history, demographics, medical history, the diagnosis of their current mental health and medical problems. You have your high priority treatment goals, your measurable objectives. You have a timeline or frequency for treatment progress, and we're really going to touch on that timeline today. And then, of course, your ability to track progress. So these are some of the things that the treatment plan includes. Well, a lot of people say, well, what's the actual purpose of the treatment plan? Well, the purpose of the treatment plan is just to guide a patient towards reaching their goals. It helps you as a clinician monitor the progress, and if you need to make treatments adjustments when necessary, you can do that. You might think of a treatment plan as kind of a map that points the patient towards a healthier condition. So without a treatment plan, a patient, or if you call them a client, doesn't matter. There's some people say client exclusively, some people say patient, some people say neither. You use the patient's name, but without a treatment plan in that individual's life, they don't have a clear direction on how to improve behaviors, how to improve their medical conditions, how to improve negative thinking patterns, or any problems that are really affecting their lives. So treatment plans just provide that structure that patients need to change and get better in their conditions. And research shows that focus and structure are critical parts of positive outcomes, whether it be therapy outcomes or medical outcomes. If you have the structure, then you can make some significant changes. So now, one thing people constantly ask me is, how do we establish the goals of treatment plans? And so one thing I want you to note is that a treatment plan is it's a team effort, and it doesn't matter if it's between the patient and the clinician or an entire disciplinary team. It is a team. It's two people that have to do it. And both parties are working together to create a shared vision and to set these attainable goals and objectives. So establishing goals of the treatment plan are one of the hardest things that clinicians have to do. So I'm going to offer you some alternative methods to establishing those goals, some that you may not have heard of before. And after you've realized the goals, you can determine the objectives by asking yourself, what does the patient need to do to accomplish the goals? What needs to happen for this goal to occur? And what can I help them do with those objectives? So one of the things that is really helpful is something called SMART goals. How many of you have heard of SMART goals, just out of curiosity? All right, excellent. So a lot of you have heard of these SMART goals. So you are very well-informed people here. If you haven't, don't worry. I'm going to take care of you. No worries. Okay. So these SMART goals are, when you work with your patient to set up goals and objectives, they can actually reach. So these are attainable, and you see that word attainable there. So when you use the rules of SMART for guidance, SMART basically stands for specific. And when you're talking about specific, objectives need to be clear and specific, not general or vague. Okay. It's easier for a patient to complete the objectives when they know exactly what they need to do. Okay. When exactly what they need to do. Not like, we want you to feel better. No, they need specific objectives. And the next thing is going to be measurable. So objectives need to set specific times, amounts, or dates for completion. So you and your patients can measure their progress. So again, measurable. The next is going to be attainable, to encourage patients to set goals and objectives they can meet. And if their objectives are unrealistic, it may decrease, one, their self-confidence. It could absolutely discourage them. So goals and objectives, they shouldn't discourage them, but they also can't be too easy. Goals should be challenging, but realistic. And then relevant. And people always say, well, what does relevant mean? Goals and objectives should be relevant to the issues listed in the treatment plan. So when patients complete objectives and reach their goals, they should be closer to the place they want to be in life, and they want to be as a person. So they need to be relevant. And then time bound. Goals and objectives, they have to have a deadline on them. Goals can be considered short-term or long-term, and we'll go over those, but objectives need specific dates to meet. So a deadline creates a sense of urgency, which actually helps motivate a lot of clients, is when you provide those type of deadlines. All right. Now, I always like to cover this part because I think it's really, really important. Um, so what is interesting is people always talk about, it is the clinician or provider's responsibility with treatment plans. But there are many, many times where you will put wonderful short-term goals and excellent interventions in place, but your client's just not going to do them. You may have the best short-term goals and interventions, and they're just not going to do it. They're not going to comply. And so this is this statement: in achieving treatment plan goals, the clinician can start the car and draw a map, but the patient must be willing to drive. Yeah. And that is so true. And I'm sure many of you, this is, you know, this is something that you've probably faced. How many of you, just out of curiosity, have within your practice, you have had really wonderful goals for your patients? They're just not going to do it. How many of you, if you feel like comfortable saying yes? So I'm getting some yeses, yes. Beverly, you brought up a good point, and you're not being negative. This is about pleasing insurance companies, and it's not. I think it is reality based, but you're right. You're not going to get reimbursement unless you do the treatment plans. You're 100% correct. So, so absolutely, absolutely. There are a lot of, and more jumping on that bandwagon. Insurance companies are really good at trying to find ways not to pay you, right? And this is kind of one of the things that they're starting to jump on. So Beverly, you're right. I'm getting a lot of yeses with people that have done this, where you've created wonderful things for a patient and they just won't follow through. And I know that's so frustrating. I have been there, and it is so frustrating. So all right. Now, one of the things that and Beverly kind of led into the next thing I was going into, regulatory requirements. Now, so we have the reimbursement issues, but let's talk a little bit about regulatory compliance with these treatment plans. If you go in, these are some of the, I put them up, and we're going to review some of the requirements for treatment plans for these agencies. Now, I only have time to go over kind of the bigger agencies, and I call them the big guns because most of you work with these agencies or at least aware of them, and some of these agencies that are up here set the gold standard. All right. And so one will do something, and the other will follow suit. That's a lot of times the way things work. But we have CMS, that's Medicare, Medicaid. We have inpatient, who has their own set of regulations or guidelines. Outpatient is a little bit different. And then we have Joint Commission and CARF. And so some of those are some organizations. Now, I had quite a few people that said, you're an inpatient, so I'm going to talk about that next. So we'll go into that. For inpatient facilities, inpatient and outpatient, I've worked and managed in both, and they are a little bit night and day sometimes. So basically, these things I've taken straight from the CMS manual. And in addition to what you know about short-term and long-term goals, because I didn't want to cover the basic things, but with inpatient, each patient must have an individualized treatment plan. There's got to be collaboration between the client and the treatment team. And we deal in Notes. We have many, many inpatient hospitals. We have many, many residential facilities, and that is just 10% of our client base. A lot of our client bases are solo practitioners that are out there. But one of the things that I see inpatient facilities get dinged for all the time, because I have the directors of nursing, the medical directors calling me and saying, this is what the Joint Commission picked up on the inpatient facility, was that clinicians for disciplines aren't all active in the patient's care. Like dietary may have met with the patient regarding a dietary consult, but dietary didn't do a treatment plan. That's an automatic ding. Same with RT, recreational therapist. If you're in a medical hospital, then if PT is working with a patient, they have to have a treatment plan on the chart. It has to be a collaborative effort between all disciplines that touch that patient. So also, they require inventory of strengths and disabilities, and the documentations of goals and interventions have got to be visible throughout the stay. And then the discharge planning must include the treatment plan. So Notes has a way to meet all these goals by linking the treatment plan through all your notes and including the entire plan in the discharge summary. So those are some of the things there. So Yes, some of you are very glad you are solo practitioners. I completely understand that. So the next one I'm going to go to is Joint Commission. As we're touching on inpatient, we're going to go to Joint Commission. How many of you, just out of curiosity, are accredited by the Joint Commission? If you feel comfortable, you please place that in the chat so we'll know. Not that many. Okay. All right. Well, just to cover them a little bit, and a lot more people are covered by CARF, but just moving on to the Joint Commission, their goals are really wanting to capture the individual words or ideas, but CARF is on the same page. They want the individual statement. That's why individualized treatment plans are so important. And they want identified steps to achieve the goals. They want to make sure you're documenting your progress. And if you don't do something, there has to be a reason for deferring a goal or objective. You can't just not meet it. You have to state that the patient is still working on it, we'll work on it later on, or that we need to continue the treatment plan, more time is needed, or the patient decided not to complete. There has to be a reason for deferring a goal. And this is actually a good practice in any treatment plan, stating why the goal wasn't met. So, and any barriers for treatment must be included in the plan. And that's one thing that we're going to go over is strengths and barriers in the plans. Now, next we're going to talk a little bit about CARF. So CARF is another big one. CARF has kind of arisen and came on the scene. And years ago, CARF was cheaper than the Joint Commission to get your certification through. There wasn't that anxiety around CARF that the Joint Commission produced. And what has happened over the years is CARF has really stepped up their game, and they're just as anxiety producing as the Joint Commission now. So when they first came on, they weren't, but now they are. And a lot of people went from the Joint Commission to CARF because of the treatment programs. They were able to do that. And so let's go over some of the CARF guidelines. So this is the treatment plans are created again. They're modified as necessary. CARF is really big on timing and regular review and documentation of symptoms. So one thing they're really big on is including the response to prescribed medication. A lot of people get dinged because of that, because they do their treatment plans and they're very like community support focused, very nursing with the long-acting injectable focused, very therapist focused, but they're not talking about how the patient is responding to their medications that they're being given. And so that is the job of the prescriber, and that is so important in the treatment plan for prescribers to talk about that response to medication. Another big thing with them is if a person is at risk, meaning they're at risk for suicidal thoughts, homicidal thoughts, then you have to do a safety plan for them. And you have to have written kind of treatment protocols, and integrated care is a big thing as well. As far as if you are integrated care, I had the opportunity to run a behavioral health primary care clinic, and it's really important that you have those medical and behavioral health treatment plan on the chart. Just like when a patient is admitted to the hospital, maybe they're admitted with major depressive episode because they're suicidal. If they have asthma, guess what? You're doing a treatment plan. If they are taking any medication like that, you're going to have to do that medical treatment plan as well. So hypothyroidism, all of that, it is all combined. And the same thing in the regular medical hospitals. If the patient comes in and has a diagnosis like schizophrenia, you have to do a behavioral health treatment plan, even if you're treating them medically. All right, if they're on any medications for that. So a lot of people, and I've had some people just in chat say, when do you review a treatment plan? Well, that's a big discussion. People always ask, well, how often should I review my treatment plans? It really depends on what I call LOS, or length of stay. And you guys have heard of that before, I'm sure. But if you work in an inpatient acute hospital and your LOS is 5 to 7 days, then you need to bump that treatment out or plan out for a week. Okay. If you're a solo therapist and you've been given 12 session authorizations and your patient or client is coming weekly, then your goals can be bumped out for 3 months. Okay. I wouldn't go to 6 months because they've only given you 12 sessions, right? So it also depends on the goals. Like some goals require a lot of time, while others may only be a week or two. So with prescribers, generally I'll say with prescribers, I would give 3 months because that's generally when the patient is coming back to get their refills. So you can, again, get that response to the prescribed medication in. All right. With CARF, though, I'll tell you, this is for you, Terry. With CARF, the longest period in between treatment plans is quarterly, depending if like you're working with an ACT team or not. That is the longest time. Do not ever bump out 6 months on that with CARF. So it's definitely a much shorter period of time. If you're in crisis stabilization, it could be it could be weekly, it could be monthly. Okay. So, all right. And now is where we're going to review how to write individualized treatment plans. This is what ICANOTES look like. This looks like. If you've never seen ICANOTES before, this is what it looks like. And we're going to do a treatment plan in ICANOTES. I'm going to show you how to do a treatment plan, the main things that we're going to be adding in a treatment plan, some helpful tips for Medicare, Medicaid. And then also in our program, because we do have a lot of ICANOTES users in here, I'm going to show you how to link the treatment plan into your notes, and also set treatment plan due dates and be able to pull data on when your treatment plans are due. Okay. Okay, so we have Alex Voss. And so here we're going to go into her treatment plan. I'm in the top right-hand corner. Now, in our program, we do things a little bit differently than some people do, but you have, when we're going to add a treatment plan, you just click the plus button. I can call the treatment plan any name I want. I'm going to name this the master treatment plan. We have general, chemical dependency, and classic. General is what we're going to be using today. Chemical dependency is for if you're dealing with ASAM assessments and you're working with a DSM, like the dimensions of the ASAM. So it has dimensions 1 through 5 there. So I'm going to go ahead and click general. I can put a next due date there. I can add it in at the end. It's whatever I want to do. And then if I'm working at multiple sites, I can pick that, or a solo site will just show up there. I'm going to go ahead and hit save, and I'm going to open up my master treatment plan. Okay. Now, let's see. Our treatment plan is going to be multidisciplinary. It's going to cover all issues, but first I'm going to go in and add a new problem or need. So I'm just going to click on add a new problem or need. As you can see, we have tons of behavioral health issues, right? We have, even if the person is substance abuse dependence or induced disorders, but you're not doing the ASAM assessments with the dimensions, you can still document that easily here. Personality disorders, non-compliance problems, mood lability, even intimacy problems are in there. And then we have adjustment disorder. I'm going to go very basic and do what people know the most. I'm going to do depression, but we have, if you notice here, we have psych issues. We have nursing, which is considered medical issues, everything from acne, fibromyalgia, all the way down IBS, rhinitis, seizure risk, sleep problems, UTIs, all of that is in there. So we also have social, which is a lot of times what people are dealing with are social issues. Not always psych, not always medical, but it could be like lack of transportation, lack of support, occupational problems, legal problems, housing or living issues, again, economic problems, self-care deficits, all of those issues there. So, but I'm going to hit mainly on psych, and I'm going to go in and pick depressed mood. Now, what's important is what you put manifested by. If you've noticed this shift in CMS, like if you're dealing with MIPS, if anybody has to deal with MIPS, the Merit-Based Incentive Program, or meaningful use, now they're requiring, and it's especially hard, they've put prescribers in that. So prescribers have to, if you have so many Medicare patients and you bill so much to Medicare, you have to attest. And now they've roped in psychologists in there. They haven't pulled therapists in yet, but it is coming. Okay, it's coming. So this year was the first year they pulled psychologists in. And what they're saying is they want everything to be quantifiable. So back 10 years ago, you could say the patient is depressed. Well, how do you know they're depressed? Because I can look at them by their body language, by their facial expressions and general demeanor. I can tell that they're depressed. But now that's not good enough for CMS. And they're making people do lots of testing, like you have to do a PHQ-9 or a GAD or a Beck. You have to do some kind of quantifiable scale so you can measure and trend your patient's outcomes. All right. And this is what we're seeing now. You can't just say the person's depressed anymore. The best practice is to say the person is depressed manifested by what's going on. So I can say they have a history of depression, okay? And I can put details or I can pull this out. It's really up to you how you like your treatment plans. Details are not required necessarily. They are helpful though, but they are not required. Then I could go in and say, they have a depressed mood as manifested by fatigue. And I could go in and say, they have some issues with fatigue. And I could go in and say, they sleep more than usual. It's interfering with daily functioning. They get tired at work. There are lots of things there. And then I could go in and talk about social withdrawal. Maybe they're having some social withdrawal, and I can add things in there like they avoid a social situation, it interferes with their daily functioning. The more details you give in your treatment plan, if you're doing it in IQ Notes or you're writing it out or typing it out, the more details you give, the better. Okay. The devil's in the details. You guys have heard of that before. So all right. So next, then I'm going to go on to, I can put in also, the feelings of loneliness. I put in complaints of feeling sad, all of those things. Now you see these little custom buttons areas. We're going to talk about this. These are going to be really important, but I'm going to move on down. Now we're going to go to the long-term goal. This is very, very important. What people are looking for in their long-term goal is going to be the patient's own statement. What does the patient say? Now, I have long-term goals here, and maybe the patient wants to have no signs of depression, or maybe they've been depressed their whole life, and that is not a realistic goal. You as a clinician know that them not ever being depressed when they are 32 years old and have been depressed for like 20 years, that's not realistic. So you might pick something that's more realistic for your patient, like will cope with feelings of depression, okay? But we're going to write here, I'm going to say, that we're going to do no signs of depression. Again, you have your scores here, so I could go in and pick some scores. Like maybe I want them to score a normal on the Beck depression scale. If you're very scale or rating scale intensive with assessments, or I want this to be their score on the PHQ-9, things like that. Now I'm going to pick a pretty lofty goal for Alex, right? Because if you guys know her, she's a bit of a trooper, right? So we're going to say Miss Voss. Now notice this in the treatment plan. I didn't say patient or client. I used the patient's own words. Now IQ Notes does that for you. It just puts in the patient's name, whatever they want to be called. If she wanted to be called Kiki, that's what would go in. Kiki will improve significantly. Whatever the patient goes by, again, it gives you a nice individualized statement. Now, sometimes this is good enough by just putting in the patient's name. However, every once in a while, you get that auditor who is not playing any games and trying to reimburse as much money as they possibly can from your pocket back to the insurance, or from your pocket back to Medicare, Medicaid. And so they will not allow this. So the best practice is you can have your long-term goal written out just like this. Like, it can be even a little bit generic, but it has the patient's name in the goal. And then you could come down and say, Alex states, I want to feel like myself 5 years ago when I was not depressed. Again, so you have that goal kind of in those professional terms, but then you have the patient's own statements below. So, all right. So next thing, again, we talked about dates. Very important to pick that target date. So I need to come in and pick a target date. If you're prescribing medication and you refill 3 months, do it then. If you're a therapist, you get however many authorizations you get, that's how many weeks I would go out. You can always come back and say, you know what? We need more time to work on these goals. They haven't met their goals. And if you send in that treatment plan showing they haven't met their goals, but we're working on them and we're doing pretty well, but we are not there yet, a lot of times you'll get more authorizations. So, but I'm going to say I've got really lofty goals here. So I'm going to go with September 30th, and I'm going to set in that target date. Sets it right in. Okay. I'm not going to add my completion date in yet because I haven't completed anything, but now we're going to move on to our short-term goals. So we've got that long-term goal down. Again, remember to use the patient's name, and it's best practice to put it in the patient's own words. So as you can see, I have some manifestations here. Fatigue, social withdrawal, history of depression. I can actually work through those. So if I go in and click Let's do depression. I can pick some short-term goals. So I can say, you know, we're going to have a decrease of depressed mood by so many points. Again, your quantifiable goals. So I'm going to say that she is, because we're only giving ourselves 25 days here, we're going to decrease depressed mood by 3 points on a 0 to 10 self-report scale of depressed mood. And I could say at this date or time, I could put that in at this date, it is currently, you know, she is an 8. I could put that in. Okay, that is helpful. That gives more information. Now we have here the frequency. Let me tell you a trick about frequency, because the auditors, not depressed. Thank you. Yes. So I'm going too fast, Paula. Can you tell? I know we have a strict timeline here, so I picked up the pace. But if we're going into frequency, people a lot of times, especially therapists, will do this. So we have Beverly, don't give up. Beverly's wanting to leave the profession and buy a pizza shop, and that sounds really cool. Okay, so but don't give up. Okay, we're all in this together. So we're gonna do frequency. I'm gonna say once, and therapists will always come in on their treatment plans and say like once per week. But here's the problem. Here's the problem. You are going to come in. What if your patient doesn't come that week? But you said you were going to do it once a week. You can't really do that. So we have the ability to put per session. All right. So you can put per session in for a period of time. So, and I could say like for 1 month. All right. Now here's our progress. Now this is our initial treatment plan, so we're not going to chart progress, but you see how you have the ability of working on, partially complete, plans to start soon, almost done, completed, and then what we talked about with them getting in the car but refusing to drive, they just decided not to complete. We also have the ability to do effective and ineffective. Okay, so we can put those in as well. So I can put all of those things in. I could even add my completion date if they completed their goal. I don't have any problems with that. So Terry, you're funny. All right. So we're going into treatment plans. Again, I'm going to talk about social withdrawal. So we could say that we want them to learn 1 social skill per week. We could say that we want them to attend an activity at least once every 2 weeks. Sorry, I'm jumping spaces here. All of these things. Now, so we're putting in our different goals, short-term goals that we want them to do. Okay. I can jump back to depression and say, you know, a lot of people like to tell the patients to keep a journal. We can do that. We could tell them to exercise. So we could go down and we could talk a little bit about exercise. I tell you what, we could do that for fatigue as well. So we're able to go into fatigue and ask them to do a little exercise. Let's do some exercise by walking or implementing a regular exercise regime, walking at least once a day for however much the patient has told you they have walked before. If you have a 450-pound patient and you put that you want them to walk 5 miles a day, that is an unrealistic goal. You can't get me to walk, and I'm not 300, but you can not get me to walk 5 miles a day, and I'm actually pretty active. So there's a lot of things that, again, we talked about realistic goals for your patient, right? So I'm going to put 1 mile. Okay, that's pretty realistic. I could do that. We can go in, again, implement regular exercise regimen. Now, here's the thing. If you get a short-term goal and you don't like it, I can just trash it. I could just take it right out. I just hit the trash can. It goes right away. All right, so not a problem with that. Again, I can go into depression, and I said journaling, and I said exercising. Let's do a little identify the causes of depression. We can do that. So lots of different things. I'm just picking off the cuff here. So next, I've got my short-term goals. Now, if you're looking at this and you're like, you know what, none of those short-term goals, I'm going to talk to my patient for me. All right. And so none of those I'm going to do. and you want to create your own. You can absolutely do that. I can create a blank short-term goal. I can create a blank intervention just by adding custom buttons. So here you're able to create everything that you want within the treatment plan. I'll show you exactly how to do that. Yes, Terry, excellent example. Use your own grounding techniques, right? That's something that you help teach them that's not going to be in a traditional treatment plan book, right? And so this, you can come in and make your own short-term goals and own interventions for these things. And I'll show you exactly how to do that. Now let's move over to interventions. And I made a promise. We had a doctor in here that said, you know, you talk about therapists a lot, and we do. And so I wanted to show you right here. Here's your disciplines: your psychiatrist prescriber. We have nursing, we have occupational therapy, recreational therapy, group therapy, psychology, dietitian is in here. We have a lot of this. So, okay, so basically we've got this in here. Y'all are having a blast in the chat, and I can see you. All right. So we have this in here, and I'm just going to pick some things, okay? So we go to short-term goals. We start adding interventions for your discipline. Now, like the prescriber, if I come in here and we talk about decreased meds, I can say, you know, the prescriber is going to prescribe medication. All right, and monitor the side effects and adjust the dosage to decrease frequency of depressed mood and minimize the side effects. And that progress is going to be monitored and documented. Again, you must do the frequency. So if you're going to see them once every, let's say, we'll say, I can even say per month or per quarter, I can do that for the duration of, 6 months. I could put that in there. All right, I'm able to do that. I'm also able to type in here. So I could say, 3 months and the duration of, let's do 1 year. Okay. Now, if you're in an outpatient setting, you could probably get away with doing 1 year as a prescriber. I would still encourage 6 months. Okay, I would. Now, here's the thing that's going to be really important for everybody as I go through these. Where if you're dealing with Medicare and Medicaid and you have those patients, especially Medicaid, yes, the doctor signs a plan too. Everybody signs a plan. Absolutely. A good question. Terry said, does the doctor sign the plan? Yes. If you are in an outpatient setting and you have Medicaid patients, it is so important to put the clinician's name, the person who is going to be dealing with. Let's say Courtney Kimmel is the doctor, and I'm going to put her right in there. You have to put the clinician's name by the intervention of the short-term goal. So now if you're in an inpatient setting, which some of you were, I think 7% of you were in inpatient, I have a polling monitor. That's how I know that. So the 7% of you that were in inpatient, you guys, you can get away with like not assigning a nurse, okay? Or you can get away with that. But most of the time you've got to assign the person that is actually going to be working with the patient on the treatment plan. Medicaid will ding you, and I've seen people denied reimbursement for this simple little thing, okay? So just make sure that's done. Now, for you folks that don't have to worry about this, and you're like, I don't deal with Medicare or Medicaid, that's not my problem. I don't have to deal with that. I'm going to show you what you can do if you don't want to identify a clinician. Okay, let's say you have community support and you're not dealing with Medicaid patients. I will show you just kind of a workaround. But now, if I said there's our psychiatrist prescriber, I'm going to RT. Now, one thing the RT person can do is do activities for depressed mood. Okay, so I could say, you know what, we're going to provide recreational activities to distract Miss Voss from depressed mood. Now, let's say the clinician is not an assigned RT. Maybe you work at a hospital and they have 5 or 6 RT people in there. I can click the little pencil and I can literally come in and type, recreational therapy. Okay. And just assign it to them. Again, I want to put the frequency, the time period, and duration. For timing, I'm not going to do that because I want to make sure we get through all this. Next, I'm going to go into nursing. And I'm going to say the nurse is going to educate regarding signs and symptoms of depression. So I'm going to click understanding symptoms, and we can document that progress. And then I'm going to go into therapist. Now, what you will see here is when I pick You've seen there's been a couple for each discipline, but when I go to therapists, we have a long list, right? So I'm going to pick the top one, self-report scale of depression, because that's what I'm dealing with, depressed mood by so many points. And there, again, I've got that there. Now, again, social withdrawal, I can talk about, or journaling, I can go on down and say, to keep a journal, I'm going to encourage them to journal. Again, time periods on this are good. This will go ahead and tell you in here, excuse me, let me just put this screen back up, that they're, that you're going to encourage and support the journaling, and you're going to go over it, share the journal with the therapist weekly. It goes ahead and puts that in there for you. Okay, so you're going to encourage them to do that. Social withdrawal, we're going to encourage activities, if it's group activities, or we can do therapy for social withdrawal, all of those things that you can do in here. So we're going to do a little social withdrawal. So help you explore behaviors and reactions that cause social withdrawal and depression. Okay. So a lot of great things in there. Now, I did tell you guys, what if I say I create some crazy goal in here, okay, or crazy intervention? I'm going to add a new blank intervention. So I'm just going to go in here and I'm going to select that short-term goal. I'm going to add a custom button, and somebody throw out their favorite snack. Paula, yes, it is okay to say the client will decrease symptoms by 50%. You're still using numbers and quantifiable goals. Good question. Good question. Popcorn. All right, popcorn. All right, so I'm going to come in here and say, and I'm going to use the patient's name. Again, very important, right? We've been putting the name in the whole time, so people cannot accuse you of cookie cutter treatment plans, which is a tirade that right now CARF is on. So I'm going to say, name will eat popcorn 3 days a week for depression. Okay, so I'm going to save this as my button. Now you can share your buttons with select users. I can share it with the entire discipline. I can share it with the entire group. All right, so I'm going to come down and hit continue. Now, if you notice, as soon as I hit continue, on the right hand side here, there's popcorn. Popcorn is going to be down in here, and I can add popcorn in. Let's do my short-term goal here. Yes. So Ms. Foz will learn to implement one social skill per week. I can click popcorn right here, and it will say Ms. Foz will eat popcorn 3 days a week for depression. All right. So it goes right in there. And that is, so someone that said the grounding techniques, you can put that in there. You can stick that right in there. Okay. So, all right. So those are our interventions. Now, one thing I said throughout the webinar was strengths and barriers. Joint Commission is big on that. CARF is big on that. CMS is big on that. They focus more on barriers. You need to say why the patient is having trouble with their goals. But strengths are really important. So I'm going to go to the strengths part. I think you guys have kind of got the process of long-term goals, short-term goals, and interventions. So I'm going to go in here and I'm going to say that, some of Alex's strengths is her family. Okay, I'm going to say that. So she has family support, and she has a good relationship with her family, and maybe she has some social support, like she interacts well with others and she has friends. All right, again, those custom buttons pop up, so you can put whatever you want in those custom buttons. Now, moving on to barriers, what we have found, because Icanotes is we're not just across the US. We are all over the world. We're in Australia, we're in South Africa, we're in Africa. We just recently have a practice in Pakistan. So a behavioral health center in Pakistan, believe it or not. So we are all over the world. Our focus is mainly in the US, though, because the compliance and regulatory guidelines are so stringent in the US compared to any other country out there. You guys are probably not surprised to hear that. But on our barriers, what we have found is across the US is barriers are really kind of focused on the locale that the person is in. Like, let's say here, I'm in North Carolina. Now, I'm in a big city of Charlotte, so transportation is really easy, right? But in the rural parts of North Carolina, they're not public transportation. So 45 minutes outside of Charlotte, there is no bus service. Uh, and so people have problems getting to their appointments. So it could be a transportation barrier. It could be the area that you live in. Maybe you live in a state that has poor socioeconomic issues going on in that state. And so in that state, people really have a problem financially and being able to get health care. All right. And then you could be in one of those states like North Dakota that has very few providers. So that is just, that's really, it depends on where you're at. So, and then you just have regular barriers where it's just emotional. They have some emotional problems and we're going to deal with that through the treatment plan. All right. And maybe there's language barriers. There can be all kinds of things like that. Now, so we've got strengths, we've got barriers. I'm going to move on to my status, and status is really important. We're going to do a face-to-face. Normally with your clients, you're going to do a face-to-face. Now, if you are a clinician that supervises other clinicians, you can do clinical review. Now, here's the thing. You cannot do a clinical review unless you are a licensed clinician. Okay, so you can't be like the office manager and do a clinical review. That doesn't work. You have to be a licensed professional there, okay, to do that. So I've got my status. Now let's look at the treatment plan. Now I've kind of goofed off in this treatment plan. So I've goofed off in this treatment plan, so it's not going to be as pretty, but if you're working with the interdisciplinary team, you see and one, you can put the type of meeting, like if it was initial treatment team meeting, the start time and end time. I can put the folks in the treatment team, so I can say that, that Courtney's a physician. I can add the patient in. Again, the one thing that we talked about in the webinar, you have to show that you have a collaborative effort with your team. Your team could be you and the patient. That is a team. That's two people. Or it can be you and a whole team of RT, PT, dietary, all of those folks. All right. So, but I'm going to come in and I'm going to say that Alex Voss is part of the team. She is our client, and meeting with her is Piper Chapman, if you guys are familiar with her. So I'm going to say Piper Chapman in there, and that is the spouse. Yeah, good question. Yes, it is the best to put the patient's name in here. And if you are looking for good reimbursement, you're going to want to get a signature on that as well. Okay, you're going to want to get a signature on your treatment plan. So that I've had people that haven't had signatures on their treatment plans for years. Then they get that Medicaid auditor that comes in and said, where are your signatures? And then they have to reimburse. So best practice, just get the patient to sign the treatment plan. All right, so we can do who is present at today's meeting if they completed their portion of the treatment plan. Now we're going to check out the treatment plan. Again, here, a lot of problems, a lot of long-term goals, a lot of short-term goals. Our program will tell you when you don't fill things in correctly. There will be statuses. Yes, Beverly, right now it's just Medicaid, but Blue Cross Blue Shield and got a little squirrely with one of our customers the other day. So, and said that they had to have treatment, they had to have signatures. Not only do they do that to a therapist, then they said that the prescriber had to have a signature on a treatment plan if they billed for the additional EM code of therapy. So just throwing that out there, letting you guys know that you may not have heard it yet, but it is right around the corner, unfortunately. Our program will let you know when you don't fill out target and completion date. It will do all of that. It will go over, interventions and status. I'm going to compile this note and save it to the chart. I can set a due date on this treatment plan. Again, here's my treatment plan. Long treatment plan, but I didn't have to type all that. Isn't that really beautiful? All right, so I'm going to go back to the chart face. There's my treatment plan. Here's my treatment plan here. It's showing up here as my master treatment plan with depressed mood. Now I'm going to show you, I need you to chart the treatment plan. I'm going to go through this really quickly because I don't have much time left in here. So if, let's say as a therapist, majority of your therapists, so I'm going to pick this. Now it doesn't matter what note you were in, what note type, you're going to have this button. It doesn't matter if you're a dietitian. It doesn't matter if you are a prescriber, you're going to have this link to treatment plan button. If you're a nurse, you're going to have it. For group therapy, you're going to have it. But in the therapist note, I'm going to say that my patient is all normal. It gives me a nice all normal statement. Ms. Voss denies any psychiatric problems. The mental status comes out. It says that, the patient is doing well in their mental status exam. And then I'm going to go to link to treatment plan right here, link to treatment plan. I'm going to drop my master treatment plan down. I'm going to select depressed mood. all my short-term goals that we talked about come right out here with all the interventions underneath it. So here's my prescriber, here's my recreational activity, here's my nurse, here's my therapist, counselor, therapist, counselor, therapist, counselor, here's my popcorn, okay, all the way down. So Clara, I'm going to go over that. So I'm going to absolutely go over how do you get the patient to sign. I'm going to go over that next. Now I'm going to come in and pick one. Okay, I'm just going to pick one. That's it, just one. So just one. That's all I'm going to pick is just one. And so here we go. So sorry about that. All right, so I'm going to select none and I'm going to say, let's do the self-report. Okay. So, or you know what? Let's do the journal. I like a journal. Okay, so we'll go ahead. We'll link some interventions in. So again, I didn't do my target date or completion date or status. So the program lets me know that, so I could go in and type that now. But what I'm going to do, and what every auditor wants, all right, what every auditor wants is they want to know how are they doing on meeting their goals and what are you doing with those plans. That's exactly what the auditor wants. And in ICANOTES, you can say that, you know what, we're going to pretend that Alex is doing good and that we're going to continue the current plan. All right. Now, if she was doing horrible, we could say the problem's worse and we need more time, or we're going to have new short-term goals, or that long-term goal is deferred. And we could talk about why that is happening. And so I can come on in here, I can go back. So I've charted to my treatment plan. It was that easy to link it up. You guys should be charting to your treatment plan every single visit, pull it out and say, we went over this during the visit. This was a goal. This was a short-term goal related to our long-term goal. This is an intervention. This is how they're doing. Now, I would not pick, obviously I have a biller in here that's making me put a billing code in. There are group rules in the program. That's not really required, but that's one of the lockdowns they have going on right now. I can come in here, turning off clinical decision support rules, sorry. And here is my note. I'm going to back out of it so you can see. There's my note, my progress note, everything in it. There's my diagnosis. And there's my link to treatment plan, depressed mood, long-term goal, short-term goal, specific intervention, and how the patient was doing and meeting those goals. Now, you guys said, how do you get the patient to sign? I can come right in here. You can do a Topaz signature pad like you sign at Walmart when you're buying something. You can just use your mouse. I can come in here and say, you know what, the patient signed, Alex signed. I'm going to go ahead and capture signature, and I'm just using my mouse right now. That's it. Okay, that's all, and accept the signature and lock it in. And then if I wanted, let's say that the parent was there or her guardian was there, I could say parent number 1, capture signature. I am right now touching my screen because I have a touch screen. So I'm not doing very well with the touch screen. Okay, it's not very, very good here, but I could do a touch screen if you needed to do that. So there are my signatures. If I went to view the PDF, that would not only would they be here as far as my progress note, I would have all of that there, my link to treatment plan, and then at the very bottom, I would have the signatures of the patient. Oops, said unsigned. I didn't click that through all the way. My bad. It did not like my touch. That's okay. My computer, I am one of those people that I get mad at it and I start slamming on the screen. I'll just be really honest with you. And so the screen is not so good. So I hope you guys don't have those problems. Perhaps I need an anger treatment plan. So there are my signatures on there. I can even change the date for billing purposes. I could change this date in here if I needed to. Now your electronic signature would reflect that. That's going to be on the actual area itself. So now, again, that's how you link a treatment plan. And within ICANOTES, I have multiple reports that let me know when my treatment plans are due. I have my treatment plan due dates. I have my clinician reminder sheet, which will show me on the clinician reminder sheet at the very bottom what's overdue. It's really important, just to overview a couple things that we talked about. Make sure you have assigned clinicians. If you're dealing with Medicare, Medicaid, make sure you're putting your timing and frequency in there. Make sure that you have quantifiable goals so that you can actually do measurements on that. I know that their BEC is decreasing. I know the PH9 is decreasing. I know that their depression, when they just rate it to me verbally, is decreasing when they see me. I know that they're charting in their journal once a week because they share it with me. Again, quantifiable goals. All right, that are definitely measurable. And then, of course, your documentation, you're going to want to chart to the treatment plan every single time. So you saw that regardless of the organization, whether it was the Joint Commission, CARF, or CMS, that's what they want. So, and again, using that patient's name in the treatment plan and stating their individual statements is best practice to individualized treatment plans. All right, guys, I appreciate your time today. It's already 6:02. I want to be very cognizant of your time. I appreciate you guys hanging in there. You were quite fun. So I do appreciate you. If you have any questions, you can email me directly at october@icanotes.com. I'm happy to help you in whatever way I can. Thank you guys so much. Thank you.